And so I will have my second speaker, his Professor Dilip.
Thank you very much. So, before I talk, this is all about clinical practice. It's not about sex, Nazar. It's about clinical practice. It's about how we manage everyday clinical care in the world that we live in, where their resources are quite stretched. So before I start my presentation, some conflicts of interest, which I have declared on this slide. I'm going to talk about the context of skin and soft tissue infections, but many of the principles that I talk about apply to many things. So can I ask you to put your hands up? How many of you work in a hospital that has acute care? Okay. And how many does not have acute care in your hospital? Because not all of you put your hands up. So I'm going to try again. How many of you work in a hospital with acute care? Right, that's more like it. So I would reckon about 80%. Okay, it's important and relevant question as we go along. So I'm going to show you a range of skin and soft tissue infections over here. And I'm going to ask you to think of one question and answer the second question. I'm going to ask you to think about, in those infections that I've just shown you, what is the most likely pathogen? And when you treat these infections, which I'm going to show you again, you can pick any of them, but perhaps pick the one that I've highlighted, a very aggressive skin and soft tissue infection. What is the most likely organism? And if you could then tell me, how would you treat? So who would respond with number 1? They would treat with a gram-positive antibiotic with no MRSA. We've got about 6 to 7 people, maybe more. Gram-positive, but with MRSA on this occasion. 4 very lonely people, maybe 3 more at the end. Gram-negative and gram-positive without MRSA, so broad spectrum cover. Okay, only 1 gram-positive and gram-negative with MRSA, even broad spectrum cover. Nobody, okay. And lastly, what we call the Harpic approach, gram-positive, gram-negative, anaerobic, and MRSA. Who would put their hands up for that? Nazir and a couple of others. Not all of you are playing the game. I know this is the end of the long first day. If you don't play the game, you will not be allowed to leave this symposium. So you have to play the game to make this presentation much more enjoyable. Okay, so let me just show you some data from a United States tertiary referral center, very much like what Tariq perhaps talked about as a typical tertiary referral center. The majority of these complicated skin and soft tissue infections were gram-positive. And only in the United States, this is very high prevalence of MRSA, particularly community-acquired MRSA, around 30 to 40% were MRSA positive. But look what the clinicians do there. They give very broad cover. They give aerobic gram-negative cover, and they give anaerobic cover. So very broad spectrum use for treating an infection that is primarily Staphylococcus or Streptococcus. A very important concept when we come to think about stewardship. So what I want to talk about is, how do we manage these infections in everyday healthcare setting? Do we ever switch patients from IV to oral treatment? And once we've switched them to oral treatment, do we ever discharge these patients back into the community? And I'm going to show you some tantalizing European data and also some very early data from the UAE as part of a Gulf study that has not quite yet completed, so I can't show you the full data. And perhaps we'll explore some of the lessons from that. Because when I was at medical school, which was in the late 70s, early 80s, it was all about a drug works in a clinical trial, that's efficacy, and it's safe, and it came onto the market. But now, in this decade, it's all about how effective it is in clinical practice. It's also to do with efficacy, but implementation and appropriate use of that drug for it to become more effective, clinical effectiveness. We want also to use what we do more efficiently, doing the thing right. And I think regardless of wherever you live, the cost and the use of the resources associated with that episode of infection is equally important. And also we want to ensure that the patient outcome is optimal. Look at the healthcare expenditure that now in the Gulf countries compares to many of the European and Northern American countries. You spend less GDP per capita, but increasingly that is going up in terms of the GDP spent on an individual population. So the resource question is becoming increasingly important to your healthcare system as well as to healthcare systems from other parts of the world. And I have this argument all the time, regardless of whichever healthcare system you work in. Because if you really want to make true savings, it's not that you use one antibiotic compared to the other. It's that you shut down hospital beds or you sack healthcare professionals, because those are the fixed costs that really account for up to 90% of all healthcare expenditure. It's really the small 5 to 10 to 15% of non-fixed costs that you can do something with, that you have some control over. And that, to me, is you've got to make sure that you use that money in an efficient way, but at the same time, we owe it to the patients that we look after, that we ensure that that care you provide with that resource is high quality and the patients are satisfied. One of the mechanisms of trying to use what you've got more efficiently is reducing the length of stay, regardless of whether you have a DRG or a fixed National Health Service type system if you live in Scotland, but England now is much more, for example, a DRG system. But to me, length of stay is about efficiency. It's not about making large amounts of savings, but you actually just improve what you've got with the resource that what you've got. So, another question for you. In a 10-year period in acute care in European hospitals, I can give you this data for the Gulf because it's not yet in kind of published form. What do you think was the mean reduction in length of stay in 1998 to 2008? 3 to 4 days, hands up. Okay, 1 to 2 days. All right, a few. 5 to 6 days. A few. No change. And haven't got a clue. All right. Okay, I'm glad you're honest, ladies, so well done. Okay, the answer is around a 1 to 2 day reduction. Just think the way we provide healthcare. We have short stay care. We have much more rapid throughput of patients. And certainly, you know, when I came in early 1993 is when I started as a consultant, we used to keep patients with skin and soft tissue infections for days on end. They used to enjoy breakfast, they used to run laps around the ward, and eventually I thought I would discharge that patient eventually to go home. We can no longer justify to do that. That brings me on to my next question, is what do you think has been a reduction in beds, the capacity, not the length of stay, but the beds in the last 10 years in acute European hospitals? Less than 10%? Nobody? Okay, one person. 10 to 20%? All right, quite a few. More than 20%? And then no change or don't know. Okay, okay. You see, near 20% reduction. So just think about it. Reduction in length of stay, reduction in bed capacity, the perfect storm for why our hospitals in acute care are under such a lot of stress. So when we did a survey with Matt Dryden and I a long time ago during one of the ICMIDs, we asked doctors and clinical pharmacists, do you think any of these parameters around not microbiological or clinical parameters, but any health resource parameters were of value? And the majority said that length of stay and reducing duration of IV therapy was valuable to them. And I'll explore that a little bit further. So, is length of stay valuable in your hospital? You've got to be honest here. 1, no. Hands up. Okay, so a couple of you said not important. Yes. Okay, quite a few. And then don't know. Okay, all right. We call them the Liberal Democrats in the United Kingdom. They always vote somewhere in between, but at least we've got a few don't knows. All right, so I looked at how Saudi physicians think about hospitals. This is a fascinating paper that looked at what made people discharge patients from hospital or admit patients from hospital, because you can learn about their thinking around early discharge, and it's called about challenges in discharge planning. And I learned quite a lot. Look at the data, and it shows you that there are many reasons why patients are not discharged. It's not because you don't have a protocol or a system. It's because the biggest and most important reason was inability of patient's family to take care of the patients in this Saudi study. Refusal of patients to be discharged. Nobody at home to take the patients out of hospital. The patient insisted that they remain in hospital, and delayed test results. Okay, so to an audience primarily from Bahrain, does this ring a bell? Is this true or not true? Okay, some of you are saying that these kind of barriers perhaps are important also in other Gulf countries outside the Saudi kingdom. So when we look at how we manage the use of antibiotics in everyday clinical life, the data, and Tariq didn't show these. These are one of the interventions that we, probably less relevant in an intensive care unit, is how we switch patients quickly. Because remember, we're in an age in which we've got fantastically bioavailable agents. From the quinolones to comoxiclav, to metronidazole, to linezolid, to a whole bunch of drugs that are very bioavailable, so we can with confidence switch patients from IV to oral. It is one of the easier things to do. Many of the stewardship programs that start the beginnings of a stewardship program will use IV to oral as one of their targets, the so-called low-hanging fruit. And in the United Kingdom, Mark and Philip are here as part of this strategy in which we call you start smart, and we heard about sepsis treatment earlier. You start smart, but the focus bit is around reviewing the need for the antibiotic, the microbiology, but importantly, can we move them from IV to oral around day 3 or day 4? So it sits very comfortably, very appropriately with the antimicrobial stewardship strategy. And if you look at a large survey of Belgian hospitals, it was one of the key strategies that they put in place to ensure that people thought about switching from IV to oral. Whether they were successful is a different story, and I'll talk about that very briefly. So, in your hospital, do you have a protocol? Not how you implement it or anything. Do you have a protocol? No. Hands up. Okay, I would say about 15. Yes. All right. Not many more, and mainly I'm ignoring the UK law at the beginning, but who says no or yes again? Beg your pardon? Hands up, yes. All right. And don't know whether you have a protocol or not. Okay, so some of you are not sure whether you do or not. Well, this is data from Belgium that looked at where the opportunities for IV to oral. Let's face it, the mortality and morbidity and complications from skin and soft tissue are low compared to pneumonia with hypoxia, intra-abdominal sepsis. So the opportunity from switching from IV to oral is the highest in skin and soft tissue infection. But if you look at this data, they were the greatest lost opportunities for switching patients from IV to oral. So we're losing the opportunity. Can anything help it? Can we use a lever? Do we have an indicator that our hospital managers and systems monitor to think about persuading people from switching to IV to oral? Well, they're coming. These are now the new transatlantic task force, and one of the things that will come in 2016 is recommendation that criteria for IV to oral must exist and must be implemented across all European and US hospitals. So the indicator, quality indicator people stuff are looking at. So do you measure? I won't ask this question because I'm going to run out of time otherwise. But we asked this question in a follow-up survey, which is soon to be published. And only 52% actually had a protocol they were aware of, very much like what you said. And only 46% actually had a discharge protocol. So again, the awareness, the availability of a protocol from IV to oral or discharge is limited. Now, I want to show you this very large study with some conclusions at the end. We wanted to understand across Europe what was happening in real-world setting. There was a paper for skin and soft tissue infections, but not MRSA, that showed a wide variation in practice. People were kept in hospital for about 15 days. Some were discharged, but relatively small percentage. But importantly, very few actually received IV therapy as a continuum of care, and very few got complications or readmissions to hospital. Again, this was something safe that you could do. So this was the beginning of why we wanted to examine data further. So we undertook a very large study in 12 European countries, and to explain the study to you, what we did was we looked at what happened in everyday real world, and if you then applied switch and discharge criteria, what you could have done as opposed to what is currently happening. And the gap between the two is the opportunity that you are missing for earlier switch or for earlier discharge. We used criteria that all of you will agree with. We road tested them with many clinicians across the world. Improving fever, white cell going down, less snow sepsis. They were taking oral medication, all the things that you think would be appropriate. And in terms of the discharge bit, they obviously had to have appropriate criteria for discharge, which I'll show you. I beg your pardon. I'm sorry, I'm just picking this through this quickly. They had to have no other reason to stay in hospital apart from their infection management. Those are the kind of additional bit that you needed to have for early discharge criteria. A very large study of around 1,500 patients across those 12 European hospitals. I've already looked at what criteria we applied to what was actually said, what the clinicians did in terms of switch eligibility as well as discharge eligibility. And what we found was a patient population familiar to the slides I showed you on that first slide of extensive cellulitis, infected ulcers, some diabetic foot infections, but without osteomyelitis. They had, many of them required surgical procedures, and the key message was that all of them had to have proven MRSA infections, as opposed to the first study I showed you, which would be skin and soft tissue from any pathogen, not only MRSA. And this is the punchline. When you compared to what actually they did, to compare to what actually happened, in terms of switching from IV to oral, there was a 6-day opportunity. So 33.6% of all patients were eligible for switch according to the criteria we agreed, compared to what was actually done. When we looked at the discharge capability, nearly 38% of patients could have been discharged as opposed to actually being discharged. That is a huge difference and lost opportunity. And if you put a dollar or a euro sign to that, which was around 2,000 euros per early discharge patient, because you're keeping them in hospital longer. If you look at the variation, look at across Europe. There was no one country that was greatly better, but you can see that the Greeks really stood out, and they stand out for many reasons, as you can imagine. We can also look, when it came to switch as well as discharge, again, there was a great variation across the Europeans. Slovakia did very well in terms of discharging their patients. But again, if you start breaking it down by countries, the numbers become quite small and of not statistical significance. We've then done exactly the same study with UAE clinicians, and they found an even bigger difference, just presented as an abstract at the last ECAC. In terms of 62% were eligible and not switched, and 33% were eligible for discharge and not discharged. So again, what the study from the UAE showed is the opportunity for switch and the opportunity for discharge are being lost because people are not applying well-validated and well-recognized criteria. When we looked at coming back to the European, this is another way of showing that rates of switch, and even in our United Kingdom, the rates of switch was only 16%. And Phil and Mark sitting, and maybe Mike sitting at the front say, we do much better than that. So that may be your hospital. So I'd quite like to know in your hospital whether your switch or criteria you apply and whether you do anything like this. But the interesting bit is when we correlated, sorry, this is a very busy slide and it's not my intention to show you that, we looked at why. Was there any correlation in which there was an association between early switch and early discharge? And the important one we found is whether your hospital had a protocol for switch or for discharge. So the availability of a protocol helped people persuade, encourage, remember to switch earlier and perhaps discharge earlier. That was one of the strong markers from this study. And if I showed you the structures that existed in the European hospitals that we surveyed, most of them had an antibiotic subcommittee. All of you will have an antibiotic subcommittee. But do they actually help in doing anything? Well, many did not have a protocol for either switch or discharge. Again, it shows this consistent correlation between having these protocols and actually being able to do what you want them to do. If you looked at why patients were admitted, majority got vancomycin. That is still a standard of care for empiric, initial, and then proven therapy against MRSA, skin and soft tissue infections. When you look at discharge, not all patients were discharged on oral treatment. Around 30% were discharged. Majority were discharged on linezolid. Some, interestingly, on clindamycin, so they must have that susceptibility pattern. And interestingly, a small percentage, 11.9, on cotrimoxazole. So these were the kind of oral antibiotics patients were using, or clinicians were using to discharge their patients with proven MRSA, skin and soft tissue infections. But we did a sub-analysis of the study, and we found very depressing data. And I challenge you in the Gulf countries, how you use vancomycin. You underdose vancomycin. Majority of the vancomycin was flat dosing. Majority of teicoplanin was much higher, which it should be, than the recommended dose according to the SOP for teicoplanin. And look at daptomycin. The recommended dose for daptomycin was 4 milligrams per kilogram. More than 81% of these hospitals used a 6 milligram per kilogram or higher dose. So again, that begins to make you think that the cost differentials become quite important because people, clinicians, very often quite rightly, are using higher doses. So, what does that mean in terms of messages? This is my last slide, but again, I'm going to ask you, what is the one key message that you think you have learned? That there was a mean reduction in length of stay and inpatient bed capacity in European acute care between 1998 to 2008. Is that the key message that you learned? Hands up. All right, so some of you took that as an important message. I want you to make you think of which is the most important message when you go out of that door in about 3 minutes, you will take away as from this presentation. That I didn't show you the meta-analysis of CSST. I suggest linezolid officer. I forgive me, I didn't show you that data. My third bullet point is IV to oral switch is a common recommended antimicrobial stewardship target. Okay, so quite a few think that's an important message. My fourth one is IV to oral switch and discharge for these infections is underused in 1/3 of opportunities in Europe and 2/3 of opportunities in UAE. Okay, so some of you took that as a message. Linezolid is the most frequently used oral discharge agent for these infections in the European study. Okay, no, you all seem to know that, or that's not a message you took. And finally, flat-based dosing for glycopeptides and daptomycin is common practice between 74 and 90 and 40% in European hospitals respectively. Okay, so 3 or 4 of you took that message. So in a sense, what I've articulated to you is that these are the key messages from this presentation, and all of you have recognized the importance of each of them, some more than others. But I hope that in a sense it illustrates that evaluating everyday practice will inform what we can perhaps do better. And I think having these switch therapy protocols and implementing them through stewardship programs is a very effective way of delivering this component of stewardship. Can I thank you very much for your attention? And this is where I live, and these are all my houses in Scotland. And you're very welcome to come and visit all of them the next time you come and see us. So thank you very much. Okay.